All right, it looks like we have a few more people joining, but we will go ahead and get started. So, hello everyone again. My name is Jenna Sarda, and I will be your host today for your coffee break. In a moment, we'll hear from Tushar Dungarani, one of our clinical specialists at MD Clone. He'll be sharing one of the features of our Atoms platform, which is longitudinal data organization. A few housekeeping items before we begin. During today's coffee break, lines will be muted and a recorded version of this session will be made available, which we will email to you within 24 hours. We will have 5 minutes at the end for Q&A, so please feel free to submit your questions in the question box throughout today's coffee break session. And with that, Tushar, I'm going to hand it over to you.
So I want to welcome everyone to MD Clone's Coffee Talk. Today we'll be discussing longitudinal data and the value of organizing patient data on a timeline from beginning to end. My name is Tushar Dungarani, and I am an internal medicine physician, and I work on the clinical team for MD Clone. In my past life, I have worked at 2 large health systems as a clinician and leader with a focus in hospital medicine operations and quality improvement. So today, we'll be talking about the what, the why, and how healthcare data and time relationships drive meaningful patient care results for both quality and operations, and it also helps drive research. I will also talk through a case study and finish up with a Q&A session. Before we talk about longitudinal data, let's talk about the current state of where healthcare data lives. The picture you see is an example of a table of just one data source that contains different types of data, whether it's admissions or diagnosis or bills or payments, procedures, medications. All of these different properties can live within one data source. The EMR is likely the richest data source that you've heard of, but there can be over 30 data sources for a health system. And some of that may be legacy data systems. And such in life, not all data sources are created equal. Imagine for every data source your health system has, the tables and columns of data would have varied amounts of both data fullness and data quality. One data source may bring you some demographic info, use ICD-10 codes for diagnosis, while another has a more robust demographic data source, but only provides free text diagnosis. This data source could be your current EMR or a legacy EMR. This could be a procedure or radiology database that lives outside of your electronic medical record, or it could be a billing software that your clinicians may use. Each of these data points comes with a timestamp, and every individual ICD-10 code that lives in your system for each patient may have 10 or 15 data points around it. And so you can imagine making decisions on what timestamp is important, what do the different timestamps mean, and how can we get meaning from it? A lot of questions, and hopefully we can answer it during the session. So longitudinal data refers to an organization of patient events which require an associated date and time. These events are then organized in order from beginning to end along a timeline. The date and timestamp attached to each event, such as birth, an admission, a lab test, a bill, or a payment, create a longitudinal timeline with millions of data points that are stored in a data warehouse. Each variable may have multiple timestamps depending on what you're studying. For the example of an influenza swab, there may be an order date, a sample arrival date, a final read date. Each of those outputs provides a different story depending on what you're studying. If you're studying a surgery, for example, you may want to know what happened before that surgery. Did the patient have any comorbid conditions that led to the patient needing surgery? What happened afterwards? Did the patient come back to the hospital for a complication? Are they doing well? Did they make their physical therapy appointments? And I think the other important aspect to study is how your health system timestamps data. One version of data may be timed at the end of a hospital stay versus when it happened in the hospital. So understanding your data is very important. And it'll also help you understand what you can do with that data and if you need another type of data source to build the story you're looking for. So why do we care about time relationships? Are they important in healthcare? Healthcare is full of situations where patient lives, patient care, quality operations, regulatory demands depend on time. From a macro level, looking at certain critical situations like door to balloon time when a patient has an acute heart attack, or getting the right type of medication to help with certain types of stroke. Delivering the standard of care for both critical and time sensitive conditions all require an understanding and need for temporal data. Reducing the time it takes to get a patient from the ER door to the procedure table and make it less than 90 minutes because it saves lives is important. Or if you're trying to get your patient through the labyrinth of the healthcare system, from the time your doctor suspects that you have cancer all the way to getting your first cancer procedure or treatment. Knowing the numbers of patients who had cancer isn't enough to solve these challenges. It's not enough to keep asking our healthcare teams to simply work harder. We have to look at all the steps and how time affects each of those steps. For a cancer patient, they may have to get an imaging test, which requires an insurance authorization. The same thing could happen for their treatment plan. And so instead of having a generic answer for solving some of these situations, understanding where the time gaps are so that we can identify where to solve each of the issues in your healthcare system. There's also a lot of flexibility to work with data around specific cohorts of people. There's a lot of talk about precision medicine and what it is. There's terms that are thrown out there such as 30-day readmissions. Is that impactful for your patients? We do know that it's a regulatory requirement, and so everybody looks at it and everybody follows it. But is that really the gold standard? Should we look at a shorter period of time or a longer period of time or everything? Should we look at all three of those conditions? Tailoring care to a specific type of population is important. Somebody may not have the ability to get to every visit because of social determinants. And so are we going to hold them on the same standard as somebody who has maybe more means and more access to healthcare? So what's important to our healthcare users? Does order matter in healthcare data? The United States spends $2.2 trillion on medical care and knows a lot less about the insights from that data that is produced from all that care. Aggregating all of the data types that you see on the slide so that your clinical and non-clinical teams can make data-driven decisions to improve patient care is challenging for health systems and usually even more difficult for your care team to access. If you're lucky, you can ask an analyst or someone with SQL knowledge to build a very specific study, assuming you even know what your data looks like, let alone not having the ability to quickly change both your variables and time relationships on the fly. Is there even enough good data to build a study, or is there a surrogate data point that is more populated in your database that may answer your question? We had a customer recently ask about building a cohort to study acute pulmonary embolism, and they wanted to search it through some traditional methods of maybe an ICD-10 diagnosis. But their health system coded diagnoses at the end of a hospital care admission, and so it was hard to attribute when a patient had the actual event. And so how do we create flexibility and creativity with our data? And how do we identify other timestamps that may solve our question at hand? And so what our customers did was they looked at a specific type of CT scan with contrast, and they were able to tie in both the ICD-10 code and the procedure code along with a natural language processing software to identify that the patient had an acute blood clot during their hospital stay. And that was the population they wanted to study. And so it's important to not only have the data, but also have timestamps so that you can have flexibility in terms of answering the question that you're looking for. So I'll be discussing a use case on the topic of total knee replacement. So this is a screenshot of our Adams platform, and this is how I would start to build a use case in our platform. And the study revolves around the procedure total knee replacement. And I picked this not because I'm an orthopedic surgeon, but because I was heavily involved with a co-management service with the orthopedic team. And I know this is an important study and an important concept in the orthopedic and hospital world because of the amount of different outcomes that could be studied and looked at to improve care. And so this slide is just demonstrating that I'm looking at adult patients who need a knee replacement. if you start looking at the naming convention, you see in the left kind of middle top that I'm looking for the first of these procedures so that I could study whether a patient needed another one or was there a complication. And so there's a timing convention associated with this first step in building a patient population. On this next page is our time-related event page. And just to give you a short description, this is how we study outcomes. We built our population in the last slide, and now in this section, we're looking at different conditions and different outcome variables. So I want to look at demographic, comorbid conditions, medications, laboratory results. And as you can see, from a number standpoint, everything has a percentage here in terms of how full the data may be. And if you think back to my other slide with how full a data source may be based on legacy systems, based on who's inputting the data, this gives you a snapshot of what kind of data is coming out of our health system. And most of these are variables that health systems are studying now. I think the fact that our platform can build this type of study in a very short amount of time is very unique. And to talk a little bit more about time relationships, as you scroll down the left side and we start to look at things like surgical details and knowing when the first cut time was. And maybe we want to study how many antibiotic doses were given around that exact cut time to make sure that there was 3 given and not more and not less. And maybe we want to know if there's any surgical site infections within 100 days of the procedure. And so all of those outcome variables have a time associated, whether you're tying it to the original surgery or whether you're tying it to a specific event or outcome that you're looking for in your time-related event section. There's a lot of flexibility with time so that you can get unique and important insights that would take many iterations with an analyst and a lot of time.
Data and the timing relationship between them is important when telling the story. If you had a blood marker for cholesterol and a start date for a cholesterol medication, such as a statin, you'd probably want to know if the cholesterol number is a number before or after the medication was started. Beyond that, it's equally important to know that your next blood draw is 2 days or 6 weeks later so that you can tell the patient's story the way it is intended. On the right, you will see a picture of how we organize and define time in the MD Clone Adams platform. There's a combination of descriptive terms and visual tools to help with that. You will see descriptive terminology such as get the first or second or last, terms such as after or before or ever. You want to see the first blood pressure between 45 and 90 minutes after a dose of your patient's blood pressure medications, or the last glucose within 1 hour of a hip replacement surgery. If you're studying your population, you may want the first address or zip code when your patient was diagnosed with diabetes. You may be studying hip fractures and how long it takes to get from the time the radiologist confirmed a hip fracture to the time the patient entered the operating room. We know that avoiding surgical delays for these patients is critical to their outcomes, and that the latest medical research has shown disproportionate time differences based on gender and race. Whether your health system uses 12, 24, or 48 hours as the gold standard, you want the flexibility with timing options. We also know that not all health systems measure start and stop the same way. All the time selections are centered around an event of your choice, whether it's the total number of antibiotics before and after the first cut time, or knowing if your patient had to go back to the OR within that admission or within 30 days. The ability to create your own unique data sets on the fly is critical to our varying health system ecosystems. Let's not forget the hospitalists, internal medicine doctors who may co-manage these patients and are responsible for medical management. Did the OR get notified about the elevated potassium or low hemoglobin preoperatively? When did that case get canceled relative to those labs? Could we have done something to act on these results? Was it minutes or hours before the procedure that the cancellation went in? Change management is difficult, especially if you don't empower your teams to solve your challenges. We know the who and what and why and how and when in healthcare. The what Well, it's the long length of stay or high readmission rates. Who's going to solve the challenge? You are, of course. Why? Because we all want better patient outcomes, less complications or penalties. And for the how and when, it's usually, I don't really care how you solve it. Just figure it out. And by the way, have it done yesterday. And if you're lucky, you get a group of multidisciplinary stakeholders together to design and tell the rest of us why we're changing our process for the third time in 2 years based on a few fixed macro data points. If you wanted your teams to solve your health system challenges, particularly that 25% of people who are skeptical and derail any big changes, they need tools and data that allows them to be creative about what the real challenges are behind the long length of stay. Maybe the PT consult order went in too late, or maybe it took an extra 8 hours longer in January for all your MRIs to get done. Longitudinal data provides context and granularity to health systems by allowing the temporal aspects of clinical, operational, and quality data answer your what, who, why, how, and when challenges you and your teams face every day with more clarity and more specificity.